Initiation of intravenous therapy. When it's time to initiate IV therapy, it's really important that we confirm the order and follow all the medication rights. That does not go away just because we're doing something different. Make sure that you review the medical record for allergies and consider local anesthetics. Anesthetic need is going to be based on client assessment, their history, their allergies, and the discomfort potential. It is important to understand that if we use lidocaine can cause vasoconstriction, so it may make entering a vein just a little bit more difficult. We always use the least invasive anesthetic method possible. We do have the intradermal lidocaine, which is effective very quickly, usually within 20 to 30 seconds, but it does require a provider order or facility approved protocol to be able to do this. We inject with the bevel of the needle up beside the vein if it's a very superficial one, and on top of the vein if it's deep. We just don't want to go into the vein. It is important to aspirate prior to injection to make sure that that needle has not entered the vein. We can do the topical transdermal cream, which sometimes is really good for your younger populations. However, it has to be applied and covered with an occlusive dressing for 30 to 60 minutes to be effective. At 20 minutes, we're beginning to get some effect, but by 60 minutes, we'll have that full effect. We can do topical vapocoolant sprays to provide immediate anesthetic action, or what we call a pressure accelerated lidocaine that uses a mild current to deliver the anesthetic over 7 to 10 minutes. It does cause some discomfort, but it's pretty minimal. Very important to document the client teaching and use of the anesthetic. So let's talk about gathering all of our equipment. It is important to verify the appropriateness of the fluid, check the type and the volume. It has to correspond to the provider's order. If there's any medications in the fluid, again, that medication needs to correspond with the provider's order. Look at the expiration dates of the fluid. Look at the integrity of the fluid container. If it's a glass container, is it free of chips or cracks? If it's plastic, is it free of punctures? There's no leaking. And the caps have to be undamaged. Look at the fluid to make sure that it's clear, that there's no color to it unless there's supposed to be color, and there is no particulate matter floating around in the fluid. Prepare that solution container label per facility requirements. At the very least, it will require the client's name, probably their medical record number, the date, the time, and maybe even the initials of the person initiating the fluid. The administration set tubing needs to be appropriate for the ordered therapy. Usually the drop factor is not going to be a big deal unless we're doing pediatrics or the very old adult population. Again, determine the integrity of the packaging, making sure that it has not been opened prior to the use, for the simple fact that that can affect sterility of the tubing prior to use. If the solution container is glass or semi-rigid, make sure that you get tubing that has a vent and prepare a label indicating when that tubing will need to be changed. Again, this is usually per facility policy. Open the package, and the very first thing you do after you take the tubing out of the package, close the roller clamp. Supplies that are needed to establish the IV site will include the cannula, and it should always be the gauge that is appropriate for the delivery of the ordered therapy and the age of the client. We want the smallest catheter appropriate for the therapy. You can have more than one cannula available for use in case the venipuncture requires more than one attempt, but there should never be more than 2 IV attempts by any one nurse. We need antiseptic for cleansing the skin. The rest of these things, except for the gloves, are usually going to be found within an IV start kit, and that does include the antiseptic for cleansing the skin, and the type will depend on the facility's protocol or just whatever they purchase and have available. You might need some tape. You will need an IV site dressing. Again, the type will depend on the facility's protocol. You will need the tourniquet and protective gloves. A couple of other things that may be required is you're going to need a normal saline flush. You're going to need extension tubing. And if your facility has the commercialized site stabilization um, tools, then you'll need one of those. And if your facility has the alcohol caps that go on the end of the needleless site, you may need those also. Within that dressing or IV start kit, you're also going to have a label, and that label will identify when that particular IV site was started, what gauge of cannula was used, and who started it. The other labels, once again, one for the solution set or solution container, one for the administration set, and if you use the time strip on the fluid container, you'll also need to create one of those. Then we need to attach the administration set to the fluid container. So if you have not already done so, you should close the roller clamp on the tubing now. When we're using primary tubing, we remove the cap from the spike and the insertion port on the fluid container. Both of those areas have to remain sterile, so take care to keep that spike and insertion port sterile. Carefully insert the spike into the port. Be very cautious not to puncture the plastic container. Once you've done this, then you turn the container upright, hang it on your IV standard, also known as an IV pole, and squeeze the drip chamber until it's about half full. Do not remove the cap from the male lure end of the administration set. In other words, the end that will connect to the client's cannula. Leave the cap on. Hold the end over a trash can or a sink and prime the tubing, getting all of the air out of it. Check the tubing for air bubbles and remove as needed by tapping on the tubing. Remember, air is going to go up and you want to go the shortest distance. If it's secondary tubing, we have to determine compatibility of the primary IV solution and the secondary solution. In other words, we want to make sure that the solutions, when mixed, are not going to cause precipitate particles to form within the solution itself. If it is compatible, then continue as follows. We'll follow the steps that have been provided above with the primary tubing set. We can prime it that way, or we can connect the secondary tubing to the upper infusion port of the primary tubing after we cleanse it. Then if we lower the secondary solution set and open the roller clamp on the secondary tubing, We will actually back prime the secondary tubing until that drip chamber is about half full, and then close the roller clamp. So basically, we've filled the tubing with the solution in the primary solution container, not the secondary. After the tubing is primed, then we're going to lower the primary solution container with the enclosed hanger that comes with the secondary tubing set. With extension tubing, if we are starting an IV cannula, we often use extension tubing. Again, remove the tubing from the package and we'll connect a pre-filled saline flush and then prime the tubing. And again, when I say prime, that means we're just getting rid of all of the air. This is very important because if we don't get rid of the air, we can actually cause harm to our client. As always, we keep the male luer end of the tubing sterile. Once IV access is achieved, we remove the stylet and then we attach that extension tubing. It does not require changing when the administration sets are changed. This again will be per facility protocol. The tubing label should indicate when it should be changed per facility policy. So then we have to prepare the site. We need to assess the client for IV site suitability per the client's status and the therapy to be administered. We will ensure privacy per the client's wishes. National standards will indicate the least invasive device with the smallest diameter, shortest length, and fewest number of lumens. It may require the use of light devices or infrared light devices or ultrasound to locate veins. With site selection, we need to consider prescribed therapy. How long is that therapy going to last? How old is the client? What medical condition are they in? And what comorbidities do they have? We need to know the client's history of vascular access and vascular availability. We also need to be aware of the presence of visible valves. You can really see these in the older adult population. They're going to be the little bumps that you can see when you are looking at the veins. These are epithelial folds that appear as the small bumps along the vein. They can actually alter the rate of the flow of the solution if the end of the cannula is too close to these epithelial folds or valves. We need to consider the care setting and the staff capabilities of being able to initiate IV therapy. And then we look at the site. There's several things that we need to avoid. If possible, we avoid that dominant arm. We avoid an arm that has a mastectomy, a fracture, or if they've had a stroke in that arm. Is there any trauma or scarring? Do they have a graft or a fistula in that arm? We should always start a site below a previous IV site. We should avoid the areas of flexion, the painful areas, any bruised areas, red or swollen areas, veins that are hard to palpation and sclerosed, spider veins, veins that are near a site of infiltration, extravasation, phlebitis, thrombosis, or cellulitis. We should always avoid the veins in the inner wrist because of the risk of nerve damage, and we should always avoid the foot or leg veins. LPNs should never access these veins anyway, and it does require a provider's order. It should only be used in the clients that have not learned to ambulate yet. In other words, children. If it is necessary to use this, we have to have that provider's order because it increases the risk of DVTs. LPNs always try the hand and forearm first and always choose the distal vein first. For vesicant or irritating solutions, we use the cephalic and basilic veins below the antecubital fossa. Then we look at the cannula. The 20, 22, or 24 gauge is adequate for most infusions, including blood components. The 16 or 18 gauge are used for some surgeries, rapid fluid volume infusions, or life-threatening situations. In the pediatric and older adult clients, these usually will require a smaller catheter. We're going to clip excessive hair, and we never shave it because it does create a potential for microabrasions, which is going to increase the risk of infection. Then we cleanse the site using an antimicrobial agent to cleanse the site. The specific agent, once again, is going to be determined by the facility's protocol. We cleanse an area about the size of the dressing to be used for at least 30 seconds. We always go from the inside out and do not go back over a site that you've already cleansed. Allow that site to dry normally without waving your hands over it. And this will prevent chemical burns once we get that IV site in. We only have one vascular access device used per attempt. In other words, we don't use a cannula multiple times. Difficult vascular access will require careful assessment and collaboration. We'll place the tourniquet or blood pressure cuff about 4 inches above the intended site, and do not leave that tourniquet in place longer than 4 to 6 minutes. If a client has compromised circulation, fragile veins, hypertension, or they might be at risk for bleeding, if a tourniquet is required, apply it loosely. In those cases, sometimes just using a coworker's hand to apply pressure will distend that vein quite well. Vascular distension can be obtained from the tourniquet. The tourniquet is usually 1 to 2 inches wide, and on occasion, sometimes 2 tourniquets at the same time. Gravity positioning will assist. A warm, dry heat to provide vasodilation from a warm blanket or a towel. Having the client do a hand pump, or lightly stroking the vein, especially with an alcohol prep. If that intended site is visibly soiled, we may want to wash it prior to preparing it. Use those non-sterile, one-time use disposable gloves. And remember that the IV insertion site should not be palpated after cleansing the skin unless you've now put on sterile gloves. So to insert the over-the-needle catheters, first of all, we need to follow our checklist for those appropriate insertion steps. Always inspect the device for possible defects and twist the cannula on the stylet to loosen. Some of those cannulas are actually kind of stuck there, and when you try and thread them off, they don't want to go anywhere. Pull the skin taut below the intended insertion site with your non-dominant hand. This will stabilize the skin and help prevent what we call the rolling veins. Um, Insert the cannula at a 10 to 15 degree angle with the bevel up. Never insert and withdraw the catheter. Watch for backflow of blood into the flashback chamber, which will indicate that you've punctured the vein. So that means we cautiously advance the device slightly into the vein. And I'm talking maybe 1 or 2 millimeters. This is required because the catheter is shorter than the needle, so you may have backflow in that flashback chamber prior to the catheter tip being fully in the vein. So we slightly lift the device and then advance that needle and catheter just 1 or 2 millimeters. Then hold that device securely and advance the catheter into the vein. We cautiously thread it into the vein. Never re-advance the needle into the catheter once we have started threading, because that can actually cause the catheter tip to break loose and create an emboli. If the catheter does not advance easily and you know you're in the vein, then we can actually remove the stylet, attach the extension tubing with the flush, and then we can attempt to float it in. In other words, we're using that saline or IV fluids to help advance the catheter. When you remove the catheter or the needle, the stylet from the catheter, we apply digital pressure close to where the catheter tip is to help prevent blood from pouring out the end of the catheter. Most IV devices will have a button or some type of safety device that automatically withdraws the needle. That's kind of a safety feature to help prevent needle sticks. Once we have the catheter threaded in, we've removed the stylet, then we're going to connect the primary tubing, the saline lock, or the short extension tubing to the catheter itself. We'll gently flush the catheter with normal saline and observe the vein where the catheter end is to see if there's any swelling. If there's any swelling, we know that the vein has not been cannulated and we have to start over. If no swelling is noted, or the nurse observes the saline traveling up the vein, cannulation was successful. If we have successful cannulation, we're now going to secure the catheter. With the winged infusion sets, these usually will have tubing already attached to them, so it's important for us to prime the air from the tubing if it's to be used for infusions. Although we don't always do this because there is a high risk of infiltration. If there is, if the winged set is going to be used just to draw blood, we do not need to remove that air because it will come out with the blood. Again, pull the skin taut to stabilize the vein. We pinch the wings of the winged infusion set together and then gently insert the needle into the vein. The bevel of the needle should be up. We insert at a lower degree, 5 to 15 degrees. And when we see blood return in unprimed tubing, we know we're in the vein. At this point, we'll utilize the same techniques as with the over-the-needle catheter, stabilizing it, making sure everything is good. To stabilize that cannula, we can use a skin barrier wipe to help maintain skin integrity. We can use a vascular access device stabilization to help preserve the integrity of the access device. It minimizes catheter movement at the hub and prevents dislodgement of the catheter and loss of that access. The stabilization device should not interfere with assessment and monitoring of the insertion site, and it should be considered the preferred alternative to tape or sutures whenever feasible. It's going to help improve dwell time of the cannula and reduce overall complications. If tape is used, we never encircle an extremity with the tape itself. That can create a tourniquet-like effect. Dressing should never be applied directly over the cannula hub. Dressings can be transparent, gauze, or a combination of gauze and transparent. A catheter that migrates externally should never be readvanced into the vein. It should be stabilized at the point of migration and then assess that proper placement in the vasculature has been maintained. If sutures were used to secure a device, then they start becoming loose or they're no longer intact, remove the sutures. Secure any extension tubing or infusion tubing to prevent flopping, and it also will improve the dwell time and prevent accidental dislodgement or manipulation of the insertion site. So we minimize the use of adhesives, but we do need to stabilize the tubing to make sure that it's not going to allow for easy dislodgement of the catheter. Make sure you apply that label to the actual dressing itself. This will include the date and time that the IV was inserted, the size of the cannula, the gauge of the cannula, the length of the cannula, and the initials of the person who has initiated the IV site. And always we document our procedure. We need to make sure that we're documenting the fluid that we're using. What type is it? How much? And what was the flow rate? Was anything added into the parenteral fluid? And if so, what type of additive was it and what was the dosage? In other words, what medication and how much? What type of cannula? The type, the gauge, the length? How many times did it take to successfully cannulate the vein? And how did the client tolerate that procedure? And then, of course, the signature of the person that performed the venipuncture. Sometimes we need to stabilize a joint if the IV was placed at an area of flexion. IV stabilization is not considered a restraint. It should always be padded and support the area of flexion. We just don't want that joint to bend. It should never impede visual assessment or circulation and should be placed above and below the joint and then secured with gauze or tape. Remove it periodically to monitor the skin underneath and do frequent skin checks at pressure point areas. Make sure that circulation has not been compromised and document the device that was used and removal for assessment and range of motion. To protect that site, we should always use commercialized stabilization devices if the facility has those available. We can place gauze underneath the cannula hub if necessary to protect the skin. If applicable, advise the client to not play with the IV site and equipment. And that would mean if they're not confused or if they're able to follow instructions. Use the joint stabilization devices if the insertion site is near a joint, and monitor those sites frequently. If a client picks at the dressing or the site or the tubing, we can secure all of that with the stretch netting. Sometimes soft mittens are recommended for client populations such as pediatric or the elderly or those that have cognitive limitations whenever there is a risk for accidental dislodgement. Soft mittens are also not considered a restraint. Physical immobilization devices to protect the vascular access device shall not be routinely implemented and should be avoided whenever possible. These are the restraints. That would include the limb restraints. If they are used, we have to do frequent assessment of the skin and site whenever implemented. And if at all possible, we should never do fluid administration by gravity. For blood sampling, this means that we can get blood from an actual peripheral IV catheter. LPNs cannot obtain blood from a central venous catheter if you are in the state of Kansas. The state of Missouri has allowed this. Use slow, gentle aspiration. Use a 3 to 5 ml syringe. It may require a tourniquet above the IV site, and we withdraw 1 to 2 mLs of blood and then discard it, especially if we've been infusing solutions, because that blood is going to be mixed with the solution itself. Then we withdraw the necessary amount of blood for the blood test. We flush the catheter and extension tubing and properly label the blood tubes. If there is a continuous infusion, hold that infusion for about 2 minutes prior to obtaining the blood.